It is said that Jeremy Clarkson recently revealed in his reality TV series that he has an aggressive form of prostate cancer. And this is the real world problem. And my topic for today is going to be on diagnostic workup and staging for prostate cancer. My references are going to be EAU Guideline 2026. The central question is no longer whether we can detect prostate cancer, rather, it is whether we can identify clinically significant disease with precision while minimizing overdiagnosis, overtreatment, and unnecessary morbidity. We know that isograde group 1 disease is biologically distinct from aggressive prostate cancer. For most patients, active surveillance or watchful waiting is appropriate and safe. However, the challenge lies in the gray zone. A small but clinically relevant proportion of apparently insignificant cancers may harbor adverse pathological features. MRI has fundamentally changed our approach by identifying suspicious lesions before biopsy. Biopsy has evolved from systematic random sampling to targeted strategies informed by imaging. For the general population, testing begins at the age of 50. However, screening should start earlier in men with higher inherited risks, including those with strong family history, African ancestry, or BRCA2 mutations. Importantly, screening is not a one-time event. PSA levels at baseline provide valuable information for determining future screening intervals. Men with very low PSA values may safely defer testing for many years, whereas those with higher baseline values benefit from a close surveillance. PSA density has become particularly important in the MRI era. A low PSA density strongly predicts the absence of clinically significant disease, whereas a higher value substantially increase risk and guide biopsy decisions. In many ways, PSA density has become one of the most practical adjuncts to MRI evaluation. Pre-imaging risk stratification includes validated risk calculators such as the ERSPC, the PCPT RC 2.0, and there's many versions online, and they can actually be used as a adjunct. And as per the impact trial, it has shown that it can avoid MRI and biopsy in up to 37% of men. So in men with PSA ranges of 3 to 20, MRI alone may not be sufficient, and PSA alone may not be sufficient. Incorporation of these calculators may be helpful. The benefits of MRI are only realized when acquisition meets established quality standards and reading is performed by experienced radiologists. This has led to growing emphasis on the PIQUAL and standardized reporting systems. MRI is no longer simply an adjunct. It has become a gateway to prostate cancer diagnosis. And the PIRATES version 2.1 has very good detection rates, up to 83% in PIRATES 5. And the recent PRIME study has shown that even without contrast, it is equally efficient in evaluating for presence of prostate cancer. Actually, more of a counseling tool in a clinic when a patient comes with an elevated PSA and an MRI. Patients with PIRATES 4 and 5, it's pretty straightforward that 31%, 54, 69, 77% does not carry much weightage. It is just to counsel patients that they need biopsy. The true benefit is actually for the Pirates tree, whereby the addition of PSA density mitigates favoring towards biopsy versus surveillance. So PSA density of 0.15 is the cutoff. But if you notice that the second column, it's 0.10 to 0.15, and the third column 0.15 to 0.2. So there is an overlap between the 0.15s. So my take on my personal experience is any patients that touches or reaches 0.15 should be offered biopsy and should strongly consider biopsy, given that the density is high. But in patients with a PSA density of less than 0.15 and a pirate scoring of less than 2 or less, surveillance is surveillance or observation is a valid option. Emerging imaging technologies such as the micro ultrasounds, which operates at a frequency of 29 megahertz, and it has shown that it is non-inferior. Along with that, we have our PSMA PET scan, which is now primarily used in the staging platform, but there are some telltale signs of its benefit on the diagnostic setting. Has very good sensitivity, however low specificity. The effect of combining PSMA PET with MRI has the best value, which is a 91% negative predictive value, and safely avoiding unnecessary biopsies. The reason why PSMA PET scan is not very specific is there are PSMA antigens expressed in non-prostate tissues, such as the salivary glands, the celiac ganglion, proximal part of small bowel, strong affinity to the kidneys and the ureter, and in the excretory phase towards the bladder, and that's where the prostate actually is. And that makes the specificity to drop. Next would be biopsy strategies, and we have evolved from systematic biopsy, which is the standard 12-core blind mapping. It has the highest rate of overdiagnosing Gleason grade group 1, missing significant anterior tumors. And next would be the targeted biopsies, which is MRI guided, up to 4 cores per visible MRI lesion. And the data from the precision trial, it shows that it detects up to about 38% for Gleason grade more than 2 versus 26% in systematic, reducing the Gleason, the ISO grade group 1 and overdiagnosis. However, the combined strategy has the best results, which is targeting the lesion plus 10 millimeters spatial margin around it, mitigates the small risk of missing clinically significant prostate cancer in MRI only pathway while restricting massive overdiagnosis. When it comes to tissue diagnosis, there is the option of transrectal, the conventional, versus transperineal, the newcomer in the block. But it's not really a newcomer, but it's something new in Malaysia, and the differences between transrectal versus transperineal is mainly owing to its infectious complication. Transrectal uses the rectum as a mode of reaching the prostate to get tissue samples, while transperineal is a direct access from skin into the prostate to get tissue samples, hence negating the need for contact with the bowel. The risk of infectious complications with transrectal is 0.5 to 3%, while transperineal almost reaches to 0% of infectious complications. Once we have obtained the specimen, the next thing would be to grade them using the Gleason grade. And the 2019 ISUP system limits grades from 1 to 5 to accurately reflect prognosis and prevent overtreatment panics caused by hearing Gleason 6 out of 10. And red flags in the biopsy cause intraductal carcinoma and cribriform pattern because they are associated with increased risk of biochemical recurrence, metastasis, and death and must be explicitly reported. Atypical intraductal proliferation, often associated with unsampled IDC, a warning sign in otherwise Gleason group 1 and 2 biopsies. Extraprostatic extensions goes without saying, it upstages the disease immediately. And tumor quantification. Following biopsy, following grading them histopathologically would be the EAU risk group, and they can be divided into the low risk, intermediate, and the high risk based on the following criteria. So just to recap, the precision paradigm: stop futile screening, do not screen men with life expectancy less than 15 years, image before intervention when possible, adapt a biopsy decision whereby omitting biopsies for pirates 2 or less, and if the PSA density is less than 0.15, it's not equivalent to 0.15 but must be less than 0.15, and using safe biopsy approaches such as the transperineal route, and standardize the language, which is the ISUP 2019 grading system. The next in line would be staging, and T2 weighted MRI remains a gold standard, but it has its own limitation. It is not so accurate when it comes to microscopic nodal disease and surgical pathways where we sample the pelvic lymph nodes carries weightage, but it definitely comes with its own risks. Imaging modalities for local staging. T2 weighted MRI, it's high in the local accuracy, but it's poor in the nodal accuracy. However, it's the most useful method for local staging and surgical margin prediction. With all the available information so far, which is the Pirate scoring of the tumor, the digital rectal examination, the PSA value, the Gleason score, all comes into a risk calculator, which actually can give a very good output on highly accurate prediction of extraprostatic extension, seminal vesicle invasion, surgical margins, as well as biochemical recurrences. And this is a useful tool to be used to counsel patients. Lymph node challenges: sometimes it's too small and may not be able to detect lymph node invasion. And then comes the role of extended pelvic lymph node dissection, because imaging may not be accurate in identifying these lesions, hence surgical options needs to be used. It comes with its own complications as sentinel node biopsy. It's something that has been it's being explored. However, it's not clinically approved, and This is to prevent the complications associated with extended pelvic lymph node dissection. So the shifting ratio, the incorporation of PSMA PET CT combined with modern risk calculators is closing the gap between imaging and pathology, fundamentally altering the extended pelvic lymph node disease risks and benefit ratio. Counseling is paramount. Clinicians must explicitly weigh the theoretical advantage of detecting low volume nodal disease against a tangible 12-month drop in quality of life, balanced with thromboembolic risk and the paradigm shift. Urology is transitioning from a stage by broad dissection paradigm to a precision targeted staging model utilizing sentinel lymph node biopsy and advanced imaging to spare patient morbidity without compromising oncological control. Thank you.